All right, then.
And I am so pleased to introduce Piruz Huda. Huda has worked as a psychiatric nurse practitioner since 2001. He's treated older adults in the inpatient, clinic, and long-term care settings. He also co-authored an evidence-based dementia care training program with Dr. Linda Terry at the UW School of Nursing. And he's made dementia education a key factor in his daily clinical practice. Currently, he's adjunct clinical faculty and UW School of Nursing and provides psychiatric assessments, medication management, and consulting to assisted living facilities in the Seattle area. And today he's going to be talking about treatment of behavioral and psychological symptoms of dementia, or BPSD. Welcome so much, Huda. We're looking forward to this.
Thank you. All right. Yeah, thanks. I really appreciate giving the opportunity to present on this topic. I've done it 2 other times, and I feel like I'm getting better at it, and I'm revising it to, well, really meet the needs that I see when I'm seeing patients and families in the clinical setting. And there's no accident that I make it a point to actually visit my persons with dementia at assisted livings. But I think a lot of my audience here are people that are working in primary care clinic. And I want to be able to give you some tools to help educate those, the families and caregivers about ways to manage the treatment, the management of the behavioral and psychological symptoms of dementia, the agitation, the anxiety, the irritability. Those are just really tough things. So just right off the bat, I just want to start with this picture. It's the cover of the Dementia Roadmap. Washington State's got this great handout and a guide for family and caregivers. And on the front, there's this beautiful picture. And I love this image, natural. And it speaks to dementia in that it's unpredictable, it's untamed. And I tell you, if you take the disease dementia and you add it to the family, to the patient and those around them, then you have this dementia journey, right? And the dementia journey can go any which way. We wish there was a road on this journey and we knew where it was going, but sometimes it's smooth and sometimes it's just all over the place and you're going to Mordor, And what helps the most, I think, and what we can be doing more for is educating, supporting those suffering from dementia so they could be geared up, ready, and they better understand the disease. So it's less chaotic and less painful. And when you reduce the chaos, you reduce the pain, you're reducing the suffering and improving their quality of life. Now, the Dementia Roadmap is fabulous because if you can Google this, all right? Google the Dementia Roadmap, you'll get this 28 beautiful pages of a PDF with links of needs. So person goes and sees their doctor, they get diagnosed with dementia and they'll show you, okay, well, you are here, a mild cognitive impairment, and your traveler's checks are over here. No, just kidding. They'll say you are heading for mild cognitive impairment. This is what the early stage will look like. This is what the moderate stage will look like. And these are the things you need to be thinking about, okay? And be ready for when you do have to give up your driver's license, when you likely will need 24-hour care. You will need 24-hour supervision and care, all right? So I want to be able to do the same thing for you. For the behavioral disturbances, is give you the information and like the roadmap handouts to make you better able to give family members something concrete to hold and to work with, okay? Now, what objectives am I covering? One, I'm going to describe what are the BPSD, the behavioral and psychological symptoms of dementia. I'm going to talk about we need to prioritize the non-pharmacological intervention. There's a lot to non-pharm. I'm emphasizing the behavior management component of it, okay? And there's the key components that I'll be describing. I'll be describing you a technique, a system that has specific components for educating the families of dementia. Realistic expectations, communication, ABCs is a behavior management technique, and pleasant events are things you add to to help the behavior management. I'll go over all this. And then how do we implement this in the clinic setting? It says the DICE approach. That's basically a way that we address BPSD during a clinic visit. All right. I want to then also touch base about the pharmacological interventions, the limits of them, but also, they are limited benefit, and how do we integrate that with what I'm talking about with BPSD, right? And I'll let you know, on the slides, at the end of the slides in the handout, I'm also enclosing this monster handout, another 18, 12 pages, I don't know, of hopefully useful information that you can give directly to families, to patients, to caregivers, okay? Now, what are BPSD, the behavioral and psychological symptoms of dementia? Okay, these are the common, these aren't the part of the disease exactly, and look at this: agitation, aggression, apathy, depression, psychosis, disinhibition, right? What isn't this? This isn't short-term memory deficits, aphasia, balance problems, and becoming incontinent. Okay, those are well, the last one's behavior, but a lot of those are just the neuropsych symptoms. These are those are the cognitive symptoms, neurocognitive symptoms. These are more psychiatric symptoms. What I'm breaking it down as, these aren't necessarily going to occur with dementia, but they do. Now, people don't come in saying my mom is apathetic. All right, they'll come in and say mom doesn't have any interest. They won't say she's agitated, maybe they will, but generally they'll say she's restless, she's pacing, won't stop, won't sit still. Maybe you'll hearing how they're at the adult family home and they're aggressive, physically aggressive, fighting people. Maybe doesn't want to do anything. They could be paranoid, and they might be doing disinhibited behaviors, masturbating in public places, grabbing at people. And then what doesn't fit anywhere is the catastrophic reaction. It's a big word, sort of like the full-on meltdown. It's like the tsunami of the behavioral disturbances. It's when agitation, aggression, disinhibition come together, and you just have a full-on meltdown, right? And this is often defined as the patient has an over-exaggerated response to a relatively benign situation. Okay, that is the person that has a complete losing it over not finding their watch, or somebody sitting in their chair, right? When do these behaviors occur? They're occurring during the dementia process later, after the initial stages, right? So I'm circling the sort of area after mild dementia, heading into moderate dementia, right? And I think actually, the more I think about it, these are the behaviors that are occurring for people as that occurs often when they're having enough short-term memory problems, when they can't remember something that happened yesterday. The classic patient, the person that you visited them yesterday, they have no recollection of that today, right? They are moving along towards moderate dementia, right? And that's probably the mental age of a 5 or 7 year old, right? And as they decline and get more disabled, need more help, what you do is you're going from a state of independence to dependence and needing 24-hour care. All right, and that's not an easy journey, right? And for when insight and judgment are impaired, right? So, but this is generally when BPSD are occurring. How often do they occur? Well, Huda, tell us. Well, I'll tell you. Let's look at this. How often is my mom's agitated? How common is that with dementia? Well, according to this, the prevalence ranges between 18% and 87%, and that may persist between 21 and 77%. What is that, right? That just tells us, this huge range tells us we don't have our terms defined. We are not great still at being able to pinpoint the frequency, okay? But what we do know is, though they do occur, not 100% of the time, not 0% of the time, but basically 97% of those with dementia will have at least one BPSD, okay? And these are the symptoms, these are the behaviors that cause the highest caregiver burnout, right? It's not that she's incontinent, is that she fights us when we try to change her, refuses to take a shower, opening up the door and trying to get out in the middle of the night, right? These are what generally, it's not the memory problems that lead to a higher need of level of care, it's usually the BPSD. So, and these often lead to unnecessary ER visits, unnecessary hospitalizations, right? Because the home is not equipped to manage them, right? And then you already know, like, well, where's this going? High costs and, aging population, more persons with dementia coming our way. And as I was saying, we don't have real consensus on what this is, right? So how are we going to manage this? All right. I'm going to use an analogy. I'm going to think of, because dementia is a chronic condition. It can lead to a terminal state and requires a lot of education. Similarly to diabetes, and say 20 years ago for diabetes, you just came into your doctor's office, they gave you some education on it, they talked to you, but now there's a set way of doing it, right? Oh, like I took my mom into her primary care, they're like, new healthcare system that said, listen, go to the diabetes classes, right? 2-hour meeting with a diabetes educator. You learn about the disease, you learn about exercise, diet. What's the story with insulin? What are the warning signs of hypo and hyperglycemia? And and of course, the benefit of doing this structured education is the person's more confident. They know how to manage the disease, less, coming in. And if they do come in, you can refer them back to the education they already got, right? And why do we do this? Do we do this for the fun of it? No, because we've proven that it's effective, that training them, you can do the studies and show that it works, okay? Gee, wouldn't it be great if we had something like this for dementia? Oh, wait, we do, right? We do. I mean, the evidence is out there, okay? And it was really, really laid out here in the Pacific Northwest. I was really lucky in 1998 to be able to work as a grad student with Dr. Linda Terry. Dr. Linda Terry recently retired. She was a clinical psychologist working in the School of Nursing, and she made it her life work to train caregivers on how to manage agitation, anxiety, depression. All right, and to prove it works, right? Which is no easy feat, okay? And from this, like I worked on this program called STAR, which was a dementia training program for assisted living, and that spun out also further into all sorts of STAR programs, STAR Seed, which is STAR Caregiver, STAR VA, and Sue McCurry, who has a couple lectures on this Northwest Geriatric series. Look her up. She talks about the evidence for it, right? But what this protocol is, it's been applied all over, and there's 31 evidence-based programs using this approach, using a structured behavioral approach. This approach is patient-centered. It's once you taught caregivers, you reduce the severity and frequency of the behaviors. You increase caregivers' knowledge, it reduces caregiver burden, and improves the quality of life with the person with dementia. I can come back and talk about that individual study I worked on if we have time later. All right, so the 4 key components of the Seattle protocol is 1, dementia education, 2, communication, I'm going to go over this, behavior management, and pleasant events. I'm going to hit each one and give you a quick rundown, all right? Now, when it comes to realistic expectations, and we first have to give a somewhat didactic information about the disease itself, right? And you guys have gotten this. If you've already heard the first 2 lectures, you learned about dementia, you learned about it as a disease, depression, what's delirium, how does it match up, right? And when we do this training for caregivers, we want to really emphasize the functional loss. We're not talking about, is this Alzheimer's, is this vascular, is this Lewy body? We're talking about they lose, just like that FAST scale, they are losing their ability. And what we're talking about is how they lose their ability to cope, right? The person with dementia, when they lose that, they're having irreversible brain damage and they don't know how to deal with stress, right? So we want to just emphasize how, this is just what happens. That the person has deficits, whether they lose their ability to get the words out, right? And they may have hallucinations, right? And with the emphasis is these persons need our help. Now, then we go into communicate. Oh, then see, there's my STAR logos like taken from an Atari cartridge or so. All right, so This big slide is 2 handouts. I'm giving this as a handout also. It's on communication. Look on the left side, practical communication. It talks about making sure, and we beat this into people. For 2 hours, we're talking about role playing and demonstrating, watching videos, okay, on how eye contact, body position, face and head movements, hand and arm movements, and speech, rate, and tone need to be slowed down, adjusted for the person with dementia, right? And I can't do it right now. I'm going a mile a minute, right? It's hard to slow down, but we have to for the persons to understand. They already have sight and hearing impairment, and then on top of it, so we emphasize practical communication. And then there's this on the right: listen with respect, comfort, redirect. It is a catchphrase that really helps people be very specific on what you need to do to improve your communication. First, to slow down, we say listen with respect. Of course, you're listening to the person with dementia, but show them you are, okay? Getting in front of them, body position, meet them at their level, and slowing it down, okay? Show them that respect. And now, now we are emphasizing comfort. What we say and how we say it can provide a great deal of comfort. And what we emphasize here is not to pay attention to what the person is saying as what the person may be thinking or feeling. Now, what does that mean? That means not as much emphasis. The person may not be saying something very reliably, but we need to get down to what they are feeling. So the person at an adult assisted living who is saying, I want to go home. I want to go home, right? Do they want to be told, no, you are at home. Your home was sold 2 years ago. This is where you live now. No, that's not going to solve, that's not answering what they need. They are basically, due to their dementia, short-term memory, and not understanding the situation. They're waking up, it looks like a strange hotel. Where am I? They're confused about where they're at. They're scared. So they need something to comfort them, answer to what is important there, to their emotion. So what I would do is I'd try to slow it down. Maybe this guy's name's Dan. He's standing on this walker. I want to go home. I go, hey, Dan, let's sit down for a minute. Sit down, sit down. Now, Dan, I hear you. You want to go home. And you're right, because this isn't your home. But you know what? It's a nice place. People are here to help you. And look, we also have all your stuff here, okay? We can't get you home right now, but I tell you, we can help you out with whatever you need, right? And I tell you what, your daughter Angela, she was just here and she was telling me how glad she is. She's so relieved that you're here. She knows you're here. And so she was just hoping that you could maybe take advantage of some of the activities here. So look at this list, right? And then we're going to try to distract him, right? But you have to first do the comfort. The phrase, when someone is, where am I? I don't know where I am. And you're answering not just with this, you're here, we're saying, we're glad you're here. So when a family member can say, instead of saying, Mom, you're here at the assisted living, it's to say, you're planting the emotions. Mom, I'm glad you're here. I'm glad you're somewhere safe. So when they're confused, they can appreciate that. And that just, the reassurance of the statement, I'm happy you're here, I'm glad you're here, provides them like a verbal hug, okay? And from there, the person might be just calmed down enough when they're agitated. I'm glad you're safe. Okay, they take a breath, and now we can redirect them, okay? Redirection is about the fact that they have short attention span and memory problems. We're using it for their advantage. The person with dementia is like an Etch-a-Sketch, right? The Etch-a-Sketch, you just shake it and the thing disappears. I tell you, I will not be able to use that analogy 2 years, right? So, let's just say the person has a short amount of RAM and that stuff can disappear in a second, right? So we're going to try to redirect them, but first we're going to provide them comfort. Example, so that person with aphasia. So example, when we're dealing with that frustrated patient with aphasia who's trying to get the words out, saying, but I can't, did you? And they're so frustrated, it's making it harder. You just want to put your hand on their shoulder and say, Dan, hey, I hear you. I can tell you are so frustrated that you can't get those words out. I understand that's part of this disease you have, but we know it. And the good thing is we're here to help you with it. So whatever you need, we'll wait with you. We'll hear it. Okay. So take your time, have a seat, and just give it, redirect then. Okay. Just last week, a family member was telling me, it's like, gosh, my dad, he knew 2 days ago that mom dying, and that was fine. And then, we're at a restaurant, today, and he says, hey, when's your mom coming by? I said, Dad, she died 2 months ago. We went to the funeral and all that. And he said, oh, and he could have argued, no, he didn't. Yes, he did. No, he didn't. Right. And instead, he just started bawling. He started crying for 20 minutes. And that's an episode that could be prevented, right? Because he's asking these questions and you're going through this. That wasn't really what he just wanted the comfort. So finding a different way to respond to this. I often say, besides looking at this, listen with respect, comfort, redirect, how about just using improv comedy as a technique? What is improv comedy? Improv comedy is yes and, meaning whatever happens, you're building on it, right? It's like you watch improv comedy, they're like, hey, where are you going, Bill? Oh, I'm heading to rob the bank. Oh, you're going to want these. 2 cantaloupes. Great. Well, I will, and you run with it. Okay. That's what I'm asking you to do. Find a way to run with the stories. Yes, Mom, not arguing. Yes, and, right? So in the situation goes, so when's your mom coming today? Oh, it's like, oh, Mom has always been that person that's running late, right? I mean, remember when we were supposed to fly to Disneyland and we missed the flight because of her? Oh, so crazy. But that was the time when we saw Linda at Disneyland. Now, and then you just go off and do another story. So take that train of thought and run off in another direction. Okay, that's what you want to do, because you don't want to be getting into this. This is your home. No, it's not. In this situation, you're people think they're not arguing because they're telling them the truth, right? But the bottom line is you are arguing with somebody with brain damage. Okay, so you got to find a different way. Now, some people will tell me, listen, Huda, I can't be lying to my mom. All right, I can't be lying to my husband. And to that, I say, well, you've tried it this way. And the thing is, each time you say it, he doesn't remember. And then you end up going through this grief again, right? And my 2 cents is, look, often you're the DPOA. You signed up for this and you take the responsibility very strongly to manage their health decisions, financial decisions, right? You are their protector, right? And you're trying to protect their quality of life. Okay, so you need to protect them. I'm suggesting protecting them from the truth that they can't wrap their heads around. All right, provide them instead the comfort that will give them peace of mind. Next topic, so pleasant events. We're going to use this as an integral part of any intervention. What's a pleasant event? It's anything. It's a pleasant event is anything that can add pleasure to a person with dementia's day. Okay, so pleasant events, cup of coffee, compliments, reminiscing, going for a walk, right? Every event can be a pleasant event and pleasant events are the preventative intervention for BPSD. Okay, and what I want to emphasize, the person with dementia cannot initiate these activities. We do these when we do these trainings, we get together with the caregivers and we say, hey, when you're having a terrible day at work, you just had the worst day, what do you do to feel better? Oh, I exercise, I call my mom, I drink, right? And so, yeah, okay, well, the person with dementia doesn't know what to do. They know they're having a terrible day, they're not feeling well, they don't know what they need to do. They need your help, okay? Now, we're going to plug these in now into a system, and this system is called the ABCs, okay? ABCs on the left, it's an ABC card assessment, and the second side says ABC Get Active. This is the treatment approach I'm going to be singing about here, and I'll be walking you through it, okay? So this works as a handout, and I'm going to use an example and break it down for you. First, we're going to look at the ABCs. Okay, when you have a situation, you want to fix a problem behavior situation. First, you identify what the problem behavior. You identify what the person with dementia is doing, who was present, where and when it was going on. After you identify that behavior, you you identify what happened right before it. That is the activator. And after that, activator behavior, you identify what happened just after the behavior, the consequence, okay? And from that, we get people to understand how these behaviors are occurring, okay? So again, we identify who, what, when, where, and then what was happening before it and what happened after it, okay? So in this example, hear me out, in a clinic visit, 78-year-old woman diagnosed with dementia 3 years ago, lives with her daughter the last 2 months. She's mostly continent, slightly balance issues, uses a walker. She's moving into moderate dementia. After leaving her stove on, found not taking her meds 3 months ago, she moved in with her daughter, okay? Daughter brings her into the clinic office, says she's not sleeping at night. She's not sleeping, and then when you start talking to her, she's telling you she's upset, okay? She has short-term memory deficit, she's fine during the day, but then she's sundowns, meaning she's predictably more confused in the late afternoon and the evening. She's more disoriented, more confused, struggles with words, and just more visibly anxious, frustrated, and irritated. She will roll around from room to room, and now she's telling her daughter, I'm going home. You know, and daughter's saying, and this is ridiculous. We've been here for 3 months, and you know, but she doesn't remember, and she just gets mad. I tell her, you know, this is where you live now, and she just gets madder and madder. And now she's mad. There are times I've had to block the door. And then at night, she's going for the door. I have to sleep with one eye open. I got to lock the door. I need to have little alarms near the bed to make sure she's not trying to get out. She needs a night's sleep so I can get a night's sleep, right? So there's a problem behavior here, okay? And really, it's more than just sleep, okay? So the behavior issue is the person with dementia is demanding to go home. That's the problem that's leading to a lot of the stress here. And we want to identify specifically. I know she's not sleeping, but right now, what's causing her a lot more stress is that the person with dementia is demanding to go home. Who's there? Well, that's the behavior. Who's there? Daughter, the person with dementia. Where? At the daughter's house. When? After dinner. Sometimes before. Okay. Well, what happened just before? What happened right before she started demanding to go home? And the daughter says, well, you know, not much. I mean, I'm in the kitchen making dinner. And then she just kind of is, you know, going back and forth. And then she just demands to go home, right? So daughter's making dinner. She's cleaning up. Patient's just sitting in the living room, gets up, comes in, says, I want to go. And I can't help but think, if I'm looking at that as something that leads to the behavior, the activator has a lot to do with boredom here, okay? The woman was sitting there, had nothing to do, thinking, well, I'm not even at my own house. There's nothing to do. If I was home, I could have things to do. I want to go home, right? So activator leads to behavior. What was the consequence? The consequence, what happened after she said she wanted to go home? Well, I told her, we are home. Mom, this is your home now. And she starts arguing with me. No, it's not. Yes, it is. No, it's not. And you know, look, we do this every night. She yells, goes back to her room, does it again, right? So activator, she's bored, doing nothing, leads to the behavior, demanding to go home. You are home. No, I'm not. Yes, I am. No, you know, and so A leads to B leads to C leads back to B, okay? And the take home question, and this is, sometimes I've done this training, I tried doing the training without the consequence piece, but it's so important to identify the consequence because it tells us what you're doing, is it making the behavior better or worse, okay? And in this situation, behavior got worse, right? And so when we're looking at this, we really want the caregiver to learn there is the big resident behavior that we're trying to fix, but the caregiver, the person without dementia, it has two opportunities to shape the behavior. They come in before the behavior and after behavior, at the activator and the consequence, to shape the behavior. Now, behaviors are not so obvious. I mean, I've been doing this so long, but the take home is the behavior has to be very specific, not a judgment, not a generalization. So what's a poorly described behavior is telling me, well, mom's confused, he's depressed, she's sundowning. They're just vague, okay? She doesn't try to remember. She's in denial about her disease. I've heard all this. She's arguing all the time, right? Better examples are being specific. He refused to get dressed. She won't take her meds. She cries a lot. He wants to go home and he sleeps all day and night, right? So you want to educate and get the behavior specific so you can fix it, right? So get active is the next step, the second half of that worksheet, okay? And on the get active, what we're trying to do is figure out how to change the behavior, all right? What's the goal in that situation? Our goal is that obviously the person will be calmer. And the question is, what can you do to break up this behavior pattern? What would you like to see happen instead, okay? In this situation, we want her to be calm in the evening, right? Okay, we want her to be calm in the evening. How can we change our approach? How can we change the environment? Well, we were talking about, there's a good chance it's boredom. Is there a way to engage her before this all happens? This is always happening on, the persons are agitated at 2 p.m. in the nursing home. Gee, they're always agitated at 2 p.m. What is that? Oh, it's change of shift. Gee, coincidence? No, it's all the noise. It triggered them. Okay. So we have to get ahead of it, get ahead at 1:30 and have the patient moved away from the commotion. So in this situation, we want them to be calm. Intervention. Give her something to do, maybe to help with dinner, right? And use our effective communication. So in this situation, we're going to say, we're going to improve our, we're going to say, maybe sit right next to her on the couch, say, hey, mom, you know what? I could really use your help in the kitchen. I'm making your famous chicken cacciatore, but I can't do it like you can. Come on, help me out in the kitchen, mom. And walk her back over to the kitchen. Maybe she'll be grumpy, but she won't be in the other room getting bored. She's in the kitchen with you, hanging out while you're working, okay? And maybe you can have her help in, okay? Did this do enough by using your communication and getting her in there? Maybe it did, okay? But maybe she's still in the kitchen and she's in there, you're at the pots, and she just says, Sandy, I want to go home, right? I mean, she wants to go home still. The behavior is still there, but not as severe, right? But she still wants to go home. What can you do here? Let's change the consequence. Let's do something. Let's work on it over here. Use effective communication, LRCR. We're not going to argue with her. I'm going to say, Mom, you're right. This isn't your home. But you know what? I'm glad you're here. And, I have all your stuff here. You can stay the night. I mean, I get it. You want to get home, but it's dark out right now. I don't want to drive at night, but I will get you home tomorrow. But please, until then, I'll get you home. But listen, I still can use your help in here. And, try to get her distracted, try to get her moving around, try to shake up this feeling and where she's at, right? So again, the interventions are made here at the activator and the consequences to change the behavior, okay? So if we're thinking about patients' behaviors and activators, I just want you to wrap your whole head around this concept, because it's a resident behavior, an activator is anything that's making this behavior run, right? So this could be even an infection, right? A urinary tract infection is the activator for a problem behavior. Mental status changes in her attention, weakness, right? There might be a medical activator, dehydration, fatigue, incontinence, constipation, right? But often in that medical visit, you've already ruled that out. It's not a medical issue. There's something else going on. And just in that very situation, she was sweet as pie here. But at home, it's a different story. What is going on in the environment, right? Is it the environment? Is it changes in the schedule? Is it a new caregiver at the assisted living who doesn't know her, right? Or is it interpersonal, being asked too many questions, the TV's on too loud, right? Being touched, given too many multi-step questions and answers, right? Or being told, hey, you need to take a bath now. You need to get changed now, right? Those could trigger me, right? And then other examples could be a person's history is their own activator, right? Their cultural background, their past habits, the person that's a retired doctor, that kind of affects how we can approach them. But, and also, a person who suffered trauma early in their life could also be, that could be shaping their behavior now, right? Those could be activators that are affecting their easy startle response, or being very anxious, or very, suspicious, whatever it is. At the same time, I just do want to say, we can't change those things. And as a behaviorist, I want to emphasize on the things we can change, okay? The behavior and what happens right before, what happens after it. And the truth is, I just see too many people. I see too many patients, and we always want to draw a line to, well, mom, she was always a controlling person. Doesn't surprise me she gets this angry, right? Or my favorite, oh, she's upset, she's anxious, she's crying. Well, she used to be a nurse, right? That always explains everything. They were a nurse, she was a nurse, right? And that explains all these crazy behaviors. No, the truth is, I see too many people who are just why does a patient get violent with dementia? It's because they have dementia. It's the brain damage, okay? And it just takes them off the hook for trying to make the family or the patient be responsible for the behavior, because they're not. Okay, now everyone loves a handout, right? This handout is out there with the simple do's and don'ts. Okay, so I got the do's and don'ts and some lists for you to give to family members. And you can look at this. Do remain calm. Don't say, don't you remember? Don't say you need to, like I said, right? And don't crowd the person. And I want you to think about how these play out with behaviors, right? When you crowd the person, when you say, don't you remember? We did this yesterday. I told you yesterday, don't you remember? Or we say, come on, listen, you need to take your medicines now. All right. These might trigger these might activate a agitated behavior, right? And so that's why we're saying, don't do these things. Instead, these more positive ways of activating. So some positive statements we might say would be, oh, I could really use your help in this situation. I'm glad you're here. I brought you your newspaper. She's confused. It's like, oh, look, it's Jenny. Oh, it's your cousin Jenny's visiting. Oh, I can't believe she came all the way from New Mexico, right? You're filling in all those holes, right? For them, so they don't have to be so confused, right? So do's, encourage. Can you do me a favor, right? And you're speaking slowly, using good communication. Those are the things we want you to do, right? And then when we look at problem behaviors, I write it all out. Someone with dementia can't just calm down. They need our help, right? So anxious behaviors could be anything: yelling, arguing, throwing things, right? Those sound like anxious, agitated behaviors. But the activators could be all over the place. It could be that they can't get words out. It could be pain. It could be they're in a new environment. It could be boredom, right? All these things we have to figure out by looking at the ABCs, okay? So one size does not fit all right? But this system of identifying what the behaviors are, what happened before, after, gives you a chance to make a plan to address the behaviors, right? Often the things are the pleasant events, which, so on this card, you can see right here, as we identify what's the behavior, what happened before, we're also asking on that problem behavior, how severe was it? Extreme, moderate, frequency, because severity and frequency, we want to measure to see if this goes down, right? And then on our plan, we're going to use pleasant events and brainstorm a plan and put it into place, right? This is the framework, right? And and I just want to say, some things will work sometimes and not the other time. I mean, people will tell me, oh, dad will never do coloring. You can't expect him to do that. Well, you have to give it a try. Give it a try. If there's one thing the ABCs can teach you is, if one thing doesn't work, try something else. That's the take-home message. I had this patient in memory unit. All right. I was in the memory unit and they were bringing a woman in for a day stay, right? The day stay is hanging out, see if this is appropriate for her, right? And this woman's a little snarky. We're in the memory unit. She sees a woman who's a little bit more confused. She's got one of the, the fake cats, and she's petting it like it's a real cat, right? And this woman says, look at her. She's so stupid. She thinks that's a real cat. And I'm like, easy, right? But I'm not kidding. 4 or 5 months later, she was that woman with the cat, okay? That's how dementia changes and how unpredictable it can be. Now, how do we apply this in our work setting? How do we apply this in the clinical setting? This is the DICE approach, okay? Kales et al. Wrote about it. Listen, it's just basically how we address dementia behaviors in our clinic setting, right? And what we're doing is we ask to, in the clinic setting, describe what's the behavior, who was there, when, what, right? Investigate, think like a detective, tease out from that story how this is playing out. Come up with and create a prescription, a plan, collaborating, and then evaluate this plan, okay? Now, I want to give you, wouldn't it be great if before, if I was the provider in the office, before I came in, I really knew what the problem was and I had a head start and we're all working on this even before they walk in the room. Wouldn't it be great? So we have this. This is great. This is called the Behave 5, developed by Sue Borson and Tatiana Sadak at UW School of Nursing. Just a brilliant 5-question checklist that I think should go in everyone's and on their initial clipboard when they're coming in if they already have dementia, right? Quick survey, find out where things are at, right? So, oh, there's already dementia. You're in for the sleep problems. Okay, I got some questions for you. Listen, does Alice get angry or hostile? Yeah. Is she hallucinating, seeing or hearing things? No. Is she irritable, frequency changing her mood? Yeah. Is she suspicious, paranoid, believes other people are stealing from her? No. Does Alice seem less interested in his or her usual activities? No. Does she have trouble sleeping at night? Yes, that's what I'm here for. Okay. So we already have a list, and if anything lights up, it was for the sleep, but now we can go back up here. Well, when is this agitation happening? When is this irritability happening? Tell me more about that, right? And a medical assistant can get some more information, right? This is going to be an early part of getting that descriptive first step of DICE, okay? So get that information, and then you want to get that whole picture. You want to ask the caregiver, okay, tell me what's going on. Play back the whole story like it's, this whole play out with your mom as if it's a movie. And from it, you get you put together the ABCs, the specifics of the behaviors, the context, right? Maybe somebody wrote a behavior log. Yeah, good luck, okay? And with the person with dementia, gee, maybe you're so lucky that she brought her mom in and she's telling her how she wants to leave every time and her mom's right there saying, no, I don't. Yeah, you do, mom. No, you don't. I mean, those are the best clinic visits, right? And so, but you just want to try to figure this out, right? Pin down what is the most distressing problematic issue. And from that description, you can survey the caregiver's knowledge of dementia and neuropsych symptoms, old term, and how, we're going to lead to strategies, right? I mean, that's one example. I mean, there are all these great, I have talk about the initial visit and telling where people are at, where their knowledge base is. A colleague of mine, primary care gerontologist, told me that she's like, Huda, this woman brought her mom into the office. And the presenting problem is, well, I want you to write a note to the assisted living for my mom saying she doesn't need to come down for breakfast and lunch, because they're trying to make her come down to breakfast and lunch and she doesn't want to. So write them a note that she doesn't need to. Oh. And this is so crazy to me, right? Because this is a situation where, sure, you can write the note and be done in a minute, but this takes 40 minutes to address. It really does, because you got to get her on the same page with the assisted living. Let her know, look, the assisted living is trying to do right for your mom, okay? And these days, I am so blunt with family members. I'm like, you are doing some adversarial shit with the assisted living, okay? And they are trying to help your mom here. They are trying to promote her coming down for meals as opposed to sitting quiet, alone in a room with nothing to do, okay? It's getting people down for meals is going to prevent her from getting depressed and moving to a nursing home. The data shows us this, right? So, I mean, so often you just got, I just think collaboration and that communication breakdown between, well, this is just, I always want to get the families and the caregivers on the same page is all I can say. So, in that very story, I was pointing out that the family member has a huge knowledge deficit on the behaviors of dementia and how to prevent behavior challenges. Okay, investigate, be the detective. Okay, so you're going to take that story, and just like in the earlier ABC we did, we're going to try to learn more specifics and figure out what is the activator here for the problem behavior. Now we've ruled out infection, hopefully, and what else is going on when the person, when she's refusing to take a bath, right? I'm trying to get her to take a bath. She's refusing all the time. I say, Mom, do you want to take a bath? No. Okay, well, that's good. Let's come up with a different strategy. Can you get her into the bathroom without telling her it's time for a bath, right? That's a, you know, it's a convoluted story, but like, you know, we have patients who refuse, like the ones that we want at the assisted living to come down for the meal, all right? Because she wants to eat in her room, she wants to stay there all day, and it's having a negative effect on her. We problem solve this. We work actively to get people down for meals in assisted livings, right? And what we do is we've learned not to say it's time for lunch, because she'll just always say, I'm not hungry, right? So we came up with a plan that said, with the caregiver say, look, you know, Gina, you have to go down and get your mail. What? Yeah, they won't let me get your mail. You have to be the one that gets it, but I'll walk you down there. This is stupid. Yeah, I know, but listen, we got to do it. So let me show you where it's at. Okay, so let's go. You get downstairs, you get off the elevator. Oh, look, here we are at the dining room, right? And so we're a little bit paternalistic, right? But we're going to come up with a plan, okay? And that's what we're gonna do. We're gonna create a plan with the caregiver. We're not gonna be too directive. We wanna brainstorm with them, get them active with coming up with a plan, right? We're gonna use the ABC card and the get active, right? So in other words, we wrote down what was the problem. We wrote down the behavior is not coming down for meals, and we came up with a plan to address it with, okay, we're going to have a couple schemes here. One is we're going to try to get her downstairs by telling her about the mail thing. Another thing is we're going to tell her that her friend's downstairs. Okay, whatever it takes. I know, of course, we'll try the other ways. Like, listen, they really miss you downstairs. They keep saying, you know, when's Gina going to be here? You know, you don't want to disappoint them. You know, all sorts of tricks, right? So come up with a plan, write it down, right? And you want them to leave with a specific printed out plan. Now, of course, we can do this on a, you know, I don't know. Where did I go? No, I'm going backwards. Okay. We can probably put this on a tablet, on a phone app, you know, and type it up. But I'm telling you, writing it down makes a difference, okay? They don't need another typed up epic patient information thing where they get that page where they can't tell where the information is actually specific for them. A specific information that identifies the plan goes a long way, all right? And sometimes you write I give them a behavior log. This is for the patient that's on a one-to-one, right? The person's so unpredictably agitated, they actually have a one-to-one person assigned to the person to keep them from, you know, getting worse. So if they're going to be there all day watching them, I say, I want you to track what they're doing, what's the behavior, what's the problem behavior, what are you doing, and did it help, right? Simple, writing down not just what they did, but what you did too, right? And then when they come back, you want to evaluate, did this work, right? And when you came back, did you put that plan into effect? Were you able to get her down for meals? Or are you able to keep her from leaving the house with this plan in place, right? Was it effective? And so often, if you just say, what's new? Is it any different? They'll say it's all the same, right? Sometimes, I don't know, man, be ready for there's no change, no change. Really, I started 200 milligrams of Seroquel and there's no change whatsoever. No change in her gait, no change in her anxiety, no change in her speech, nothing, huh? Nothing, okay, good. So what you do is you go back and look at what you documented on the last visit. Maybe you documented it for somebody, you know, maybe the person before you documented it nicely. So you can say, okay, last time she was pacing, she was restless, going room to room, demanding to go home, yelling, arguing, slapping out, worse at night. You're having to barricade the door. Is that still happening? Oh, no. I mean, I don't have to lock the door, but she is some, you know, it's better than that. It's not that bad. Well, tell me what's going on. Well, you know, okay, right? So, and then you want to hear about that, right? Prior, she was ramming her walker into people, yelling and screaming, kicking and scratching during care, times obviously tearful in fear. Is she doing that? Well, no, she's not doing that. Okay, well, talk to me about this. She's not, is she getting tearful? sometimes, is frequently, not as frequent. Okay, so you're trying to pin down the frequency and severity, right? Oh, here's my favorite. Known to hit people as they walk by without a trigger, right? Described as quickly getting distracted, shifting from happy to extremely angry. Is that still happening? Oh, God, yeah. So these are what we're treating here, right? So and you want to find this information. When I visit the assisted living, sometimes I go during change of shift so I can get everybody's opinion on people, right? So this is a plan. Evaluating, did it work? And then here, same thing, describe, investigate, create, evaluate. Same people we're talking about. Look, as you get the story and as you investigate, create, you may be thinking about, should we be thinking about a psychotropic medication, right? They're saying, you know, if she's depressed, psychotic, aggressive, consider psychotropic drug as a first-line therapy. Now, my take, it's not that the drug ever is the first line strategy. The first line, just to push up against this, the first line strategy is always the behavior intervention, okay? Trying to stop her from running out the door is still going to involve you convincing her in one way or the other not to go out the door, okay? Now, maybe the medicine will help, but I just want to say that, and also the truth is, it's not just about safety risk, it's about distress, right? The person that is so afraid or anxious. I mean, there's a woman at this assisted living I'm seeing right now. Oh my God, she was like a professional fundraiser, just a people person all her life. And now she's on the memory unit and she is the psychotically angry, just so angry that, you know, I knock on her door, she opens the door, what? You're just, oh my God, she is so angry and won't do anything. Shut up, get out. So angry. And no matter what we try, and the daughter is in tears, just beside herself, okay? We've tried all the approaches, and along this way, talking to the family, maybe we'll try a medicine along the way and see if now when we try to encourage her, if things can get better, right? Just speak quickly about meds. Look, this isn't that talk. I just want to say there are, you know, there's this article of Davis et al. On an algorithm for agitation. So you can just go on PubMed, Davies, agitation, dementia. And there's this great 20-page article that kind of describes, what does it say first? Non-pharm interventions first, okay? And then if you're looking at other treatment options, where's the evidence, okay? Often they'll indicate risperidone or aripiprazole, quetiapine, right? And then, yeah, they even have carbamazepine on here, right? You know what's not on here even? Depakote. Depakote's not on there because why? Because Depakote's never shown to work in any study. But for some reason, people are still, I can tell you what the reason is. But citalopram's on there. Prazosin has some early data, but it's very early. That's why it's lower. And then, I do not want to have to be doing ECT for dementia-related agitation. You know, they're identifying PRN sometimes given because the agitated, restless patient with dementia can be more apt to fall than the person who might be a little bit sleepier. Okay, how effective are these medicines though for BPSD? Short answer, not so effective, okay? They're less effective than the treatments that they were designed for. Meaning, you know, we don't have anything that was developed for dementia-related behavioral disturbances. We have nothing FDA approved. So what we're left with is using what is in our toolkit, okay? So antipsychotics are there for schizophrenia. They weren't developed and they don't work as effectively. Or the antidepressants are for major depressive disorder, not exactly for brain damage from dementia, okay? And sometimes they help, a lot of times they don't. When, you know, a chart review from 2018 indicated, this is in Colorado, when treating with antipsychotics, more than half had worsening of symptoms while a third had improvement. It was basically, a lot of them stayed the same and got worse, or some had improvement, right? Antidepressants, somewhat questionable. Citalopram has better data, but I'm just saying, whatever you use, it won't work without behavior management, right? And I feel pretty comfortable using these medicines just because I just know that if you're using these medicines, I don't feel great about it, but they can improve quality of life. And it's something to work out with the family, okay? Do they want to try this, right? You know, I was just talking about I didn't include all this. Risperidone has the most data for the use, but it has higher incidence of Parkinson's-like symptoms after 2 or 3 weeks, okay? And quetiapine or Seroquel, often it needs 150 or 200 milligrams for effectiveness, okay? But often that makes them too sedated, right? And these are both antipsychotics. And I tell families, look, you Google this, it says, this medicine is not approved for dementia-related agitation or psychosis. This medicine has been demonstrated to be unsafe. And here's the specifics. I tell them, look, the data tells us after they did a lot of studies, they saw increased risk of sudden death or stroke. Everyone with dementia has a 2.4% risk of sudden death or stroke in the next 6 months. That risk goes up then to 3.5%. So from 2.4 to 3.5% on being on one of these medicines, that's the risk you're taking on seeing if you can improve their quality of life. And I say, we can try it and give it a month, all right? I will be back in a couple of weeks. I will check it. We'll work with the caregivers. If there's any signs of gait disturbances, any issues, we'll stop it, right? So sometimes it works, sometimes it doesn't, but none of that's gonna work unless you're using the behavior strategies. Oh, I just mentioned that's I know there's other antidepressants that are often favored due to low side effects. Memantine, the medicine that's approved for slowing the progress of dementia, actually has data that shows it helps somewhat for dementia-related behavioral disturbances, okay? Now people will look at that and say it's slight, but I'm telling you, all we got is slight, okay? And it's a safe medicine. So for mild symptoms, we're getting there. Start getting them on memantine because it takes a good month to get started with, all right? And of course, families are going to ask about THC, CBD, and of course, they don't mind that there's no data for it, right? And people are using it, so you don't want to get too much in front, but I just don't have much less confidence in it, all right? And even if you're starting one of these medicines, you have to be making a plan for dose reducing them, because often it's when they just first move into a new unit, a new setting, that's when they're the most agitated. Once they get back to, you get used to the routine, can you dose reduce it, right? Again, I want to reinforce that the medications are not a solution. We use it as a tool to help the behavior plan be more effective. All right, and give a timeline for expectations of benefit, right? So realistic, I want to be realistic. Sometimes families are like, okay, so you got them started with med, so she's not going to ask to go home anymore. Oh, no, that's not, the medicine, what does it look like when it works? She's still going to want to go home. I just hope she's not as angry and agitated about it. And when we try to reassure her and redirect her, she's not getting more angry and upset like she is now. That's likely why I'm starting the medicine, because the non-pharmacological, the behavior management is not even working. It's making it worse. There are patients that we have a one-on-one caregiver to keep them safe, and then they're punching that person. His presence or her presence is a trigger to agitate that patient. These are people, and I want to prevent them from being hospitalized, right? So success looks like less severe, right? Maybe she still wants to go home, but you can now distract her and say, okay, yeah, we're totally taking you home tomorrow. But for now, look, I want to really hear about your daughter. You have all these amazing pictures of her, right? And I often say, look, the meds may help a little bit, 20, 30%, but it's still how you use your approach, how you talk to them, right? And what else did I say? So what I also wanted to indicate was that there are times, all I can say is families, the family of the patient with dementia. We talk about every person with dementia is, you see one person with dementia, you've seen one person with dementia. Well, gee whiz, when you see one family, you got nothing, okay? Families are the most unpredictable thing on what they'll, when it comes to behavior management education, when it comes to getting informed consent for treatment, and just to lay this all out. And the thing is, that's what I want to make easier. I want to make this information accessible for them, so it's practical, okay? And, and some people, actually, a lot of times families don't know that they're, if they're at assisted living, that their family member is agitated, and so they're upset. They're like, I want to know if my mom is this agitated because I know, this person told me, I know that if my mom is hitting them when they're trying to change them, they're not going to be less apt to want to change her. Well, yeah, that is true. That is absolutely true. I'm glad you can understand that. And that's, that's what we're talking about here. How to make this, can we reduce the severity of that aggression? All right. Boy, I just sped through this. I'm going to have a lot of time for questions. Okay, so until we have, my final thoughts were simply, until we have a better system, they're going to come to your primary care clinic for questions about how to manage these behaviors, okay? And so I want you to be able to, educate them on behaviors, what activates the behaviors, how what they're saying might be making it worse, and how a different way can make it better, okay? And I want you to use handouts so they can have this and take it with them, right? The handouts at the end include information on pleasant events and, well, all the ones I showed you here today, okay? And, I put up there, what I'm putting up there about is the medical model the best way to do behavior management and dementia behavior management. I'm putting that out there because that is our current approach, right? Oh, we got to double check and make sure it's not delirium, right? And they got to come in, right? And what's great about, the one good thing about COVID has been telehealth, because in telehealth, we learned that we can be effective virtually, right? And I think telehealth has a big role to play in dementia care. If we can do these appointments where we can, see the person, we can see the patient on video and also have this great opportunity to talk to the caregiver about what is going on and problem solve with them, all right? That I think is gonna be the crux of the future of us being able to do more remote outreach for patients and to just be more basic problem solving, right? I mean, that's what I'm doing. That's the nursing way. That's what I'm doing. I'm trying to find a way to make it work with handouts and education to empower the caregivers. When a caregiver feels like they can handle a situation, when you motivate them, that you can do this, right? That you have control over, you have some way to shape these behaviors, they're gonna stick it out longer, okay? And that's what I'm doing so often is, I'm problem solving and, I might be tied up on a Saturday at 3 p.m. just talking to this family and the staff of the assisted living to try to convince them we don't need to go to the emergency room for this, okay? Because if they end up in the emergency room or psychiatrically hospitalized, that's always a traumatic experience for the patient, and they're going to end up using the same medicines anyway, right? So let's try to avoid that. It's a harm reduction model right now for BPSD. Can we reduce the severity so we can maintain them where they live, so we don't have to uproot them, right, and cause more stress for them? All these are the little things that can improve their quality of life. So and I was just describing ways to improve your coordination of care at these facilities, right? Sometimes, like I've been at these facilities where they're, I look at the fax that went out to primary care that says, patient is agitated, hitting and punching other residents. And they get sent back a note from the doc that says, try aromatherapy, exercise therapy. Yeah, good answer, at the same time, what could they have realistically written on that to answer this? You know what this requires? This requires a phone call, right? And it's hard for each of them to get hold of each other. It's always hard for me to get hold of other medical providers, but this requires a phone call. What is going on? Find someone, you see that come across your fax, call out there, find out the story, what's going on, what's activating it, when's it happening, find out more, okay? And if you have patients at a nearby assisted, if you have 4 or 5 people that are at the same assisted living, go out and visit them once, okay? Meet the staff, connect with them, all right? Develop a better working relationship. So when you guys do call and send a communication that, you have a face with it and you have an understanding of how you work, just to knock down some of those walls. So we're not, so often I see it, the providers like, oh, look, they're saying she's agitated. They're always saying she's agitated all the time. It's like, have you seen it, right? And I've had doctors tell me, why are you putting them on risperidone? I'm like, well, because she's aggressive and hitting people. She's actively hallucinating and seeing things, and she's punching at people. And she's like, well, I never see that in my office. I'm like, right, because she doesn't live in your office, right? These behaviors are generally not occurring during our work hours, I must say, okay? And you all I can say is the caregivers aren't lying to you, okay? They are telling you what's going on, and they need help, and they need some systems to make it work. And I'll also put the word out, we have a lot of work that needs to be done. And if any nurses out there want to, we need a lot of psych NPs who are going to do older adult work, okay? All I can say is I am very busy, but I greatly do enjoy my work, because I know through these conversations, through the education, I'm helping families better understand the disease. I'm helping caregivers to better understand how to best work with people. This is, it's working with those around the person with dementia to improve the outcome. Okay, because they're all one, right? The person with dementia and the family at this stage in the disease, they're one and the same. And we got to work with one to make the other one better, okay? And nurses do this really well. So it's a really gratifying work. I encourage you to try to consider doing it. So other resources. Hey, if you like my shtick I've done another one for Northwest Geriatric series. I did a talk on early dementia planning, care planning for early dementia. So when the person, we're catching people with dementia earlier and earlier. And I think we need to have these conversations with them earlier and earlier about what's coming up. I lay that all out there with what handouts you can use from the Alzheimer's Association. So there's that. Alzheimer's Association, I have the handout from the Behave 5 is from the Care Planning Toolkit from the Alzheimer's Association. And the Dementia Roadmap, as I described, a fabulous guide for family and caregivers, right? Care partners. All right, so at that, that's what I got to say. Barbara.
Yeah, we've got some great questions. First one from Julie Dinsmore says, can you give us some ideas on when placement is recommended? Are there facilities that you believe do a better job with the patient and also in coaching the patient?
Oh, geez. Well, this is a tricky thing. I will say this. I'm glad that in Washington State, we at least require dementia education, right? For all long-term care workers, right? And I have to think that when I got working on our evidence that we showed in 2004 and 2005, when we demonstrated proving that training staff improves outcomes with persons with dementia, okay? That's huge, okay? So, they get more in Washington State than they do in California. That I know, okay? And, but you know what? This is a really tough time. I just want you guys all to have some empathy for what, you guys are all strained. Assisted livings are crazy short staffed. They can't keep their staff. And they're trying to hold it together, right? So all I can say is you interview the assisted living, you find out what they're doing, look at their ratios, compare it to other ones. But, they're all different, I have to say. And, but I can tell you is people are trying, and there's limited resources out there. And I'm just, I don't know. You're asking how do there are good ones out there. Investigate them. Each one, I don't know. I'm not going to make assisted living recommendations because there's too many I don't know about. Okay.
Well, and I should mention that, the attendees are from across the sort of the Northwest region, so not just Washington State.
Yeah, I know. Well, there's a really good one in Boise I know of, right?
So Lorraine said this was incredibly informative and the examples were great. This is great opportunities to educate CNAs who have such limited education in dementia, and they take everything so personally. Excellent presentation. Nurses with less training need this lecture, and it will be posted so it can be available. Also, a person with dementia has mild to moderate signs, but will not give the daughter power of healthcare. Daughter lives 2 hours away from the person with dementia. How do we give care when the person with dementia refuses to move or accept help?
Oh, goodness. Hey, guess what? I did this with my parents. Okay. I can write the book on it. I mean, my parents, I mean, it was very obvious. I had both my mom and dad more severe dementia, mom with mild dementia. They will not move out of the house. Okay. And early on, a social worker came to the house. My mom was like, nope, nope, nope. And the social worker says, you know, I got nothing, because there's nothing you can do. As I said in that, you know, look, I encourage you to look at that first lecture I gave, though, the one on early dementia care planning. Okay. But the bottom line is this country, we value in our society independence too much, that we let people do this, right? The disease affects their insight and judgment, right? And they believe, it's so hard, right? And of course, this person's losing her competence to even make an informed decision on a durable power of attorney. It is tough. So we want to get them early. We want the family involved earlier to avoid this. But I can't tell you how this ends well, right? Like for my mom, but for my mom and dad, they literally both had to have falls at the same time. And both end up in the ER at the same time. That made me finally fly in from, they wouldn't move out here where I could have helped them. No, we got to stay in St. Louis. Flew into town, separate nursing homes, got him into an assisted living. And of course, she loves it. Oh, I knew she would. She's so darn social, right? But you just can't help people. I mean, you're laying it all out there. You're just hoping. That's the thing with dementia. Some people, I think a lot of times medical providers are assuming that they're going to fight them on it, and it's all bad news. They don't want to talk about it. And in the hospital, they didn't want to tell my mom she had dementia. Well, you just tell her she has dementia, so then I can say this is where it's going. She's continent now. She's going to be incontinent. But there's a reason to say it, so you can plan for it. Okay, and because most people are like, there's people that don't plan for retirement, and there are people that plan for retirement. Okay. There are people that want to know, okay, this is where it's going. All right, well, I want to go look at the assisted livings now then while I'm with it. They do. Okay. And they assign their durable power of attorney when they're wide open. Okay. And then they look for that baton switch of turning over decision making. People actually want to do it. Okay. Or at least some do. You might as well try with everyone and find out who they are.
So Judy, thank you for including the Alzheimer's Association 24/7 helpline. Excellent. And then there's a question from someone who said they were recently having a discussion with a colleague about using Namenda in moderate to late stage dementia to help with behavioral symptoms such as agitation and anxiety, so that patients can be more easily redirected.
Yeah.
Colleagues stated that Namenda is only indicated to slow decreased progression of dementia and not for symptom management. I was wondering what your thoughts were on this, as I have seen Namenda used both ways in practice.
Right. Listen, when it comes to what we use to treat, I'm a psychiatric provider, okay? And nothing is indicated for this population, really, okay, first off, memantine is indicated for slowing the progression, but look at that article back on that slide I showed. I have the author and the year. Look in PubMed, find that article. It's a meta-analysis saying, look, of course, it's like you're basically using it off-label for behavior disturbances. The fact is there's data that shows it works for it, okay? That's how we know we can use it, because there's actually data that shows it works, okay? And that's a plus. Like I said, what else does, all right? Who else has data that shows it works? In other words, Namenda works better on behavior disturbances than Depakote does, okay? Because it actually has studies that showed it worked. So, and better tolerated than a seizure medicine, less side effects.
So there's been a couple of questions related to how things work for different kinds of dementia. For example, the tool that you provided for families, does that work for all kinds of dementias? And Richard Stewart is asking, are there contraindications for use of the meds for aggression for patients with Lewy body dementia?
Well, there's huge contraindications for all of them, okay? So there's risk, and with Lewy body, there's risk. Wait, what was the first question? The question was
just
about
the tool that you have included for that to
oh, okay. Yeah. So these, listen, we really are not making they are used for all dementias, okay? Dementia, I'm talking about dementia as a gradual impairment, the gradual decline of cognitive function, right? And people may have a stroke, but if you remember that in the first lecture, was it Thielke?
Yeah.
Yeah, he gave that, it's a Venn diagram. They're all in there. It's a big mishmash, and they always have a flavor of Alzheimer's in it, basically, okay? And all these approaches, you're splitting hairs. They work on all the same. Now, having said that, I did sort of point out it's about these approaches. As I talk to people with dementia in the earlier stages, these approaches will not work, right? Because the person doesn't have the short attention span and the memory problems. We're talking about, so that's what makes dementia so tricky, right? They are this way in the earlier stages, and you would not want to be so controlling and paternalistic, right? It's when they've lost the insight and judgment, and they have these short-term memories where they have these agitation, out of control behaviors often, and they break with reality. That's when they need this. But the earlier stages, you're going to tread lightly, but the ABCs work in that you're going to try something, and if it doesn't work, if the person goes, I'm not buying that, well, then okay, and you might come back with it 6 months later, okay? And then listen, this is a conversation. There are huge contraindications for antipsychotics with all dementias, okay? There are contraindications certainly with Lewy body, because we think that people with Lewy body are much more sensitive to the antipsychotics. But Lewy body patients have these terrible, by their clinical course, often have very distressing, unsafe hallucinations, paranoia, delusions, and fear-provoking, puts their safety at risk. And despite the country, we don't live in where is this person going to live, right? Can the family manage this anymore? Even at an assisted living, can they manage it, or will they keep on sending them back and forth to the ER? Somewhere along the way, gonna have to try to get a handle on these behaviors, with or without, and probably try some medicines that you'd rather not use. Okay.
So Megan just mentioned the thought that sexual behaviors like touching the caregivers can be a bit challenging. Any thoughts about that suggestion for managing?
Okay, that reminds me of another thing, which is sometimes, it is incredibly challenging, right? We certainly can't hope. So what a person could just see that as a trigger, right? That person, and see them and they grab, they're impulsive, right? And caregivers, let's say, where are they? Are they at home, or are they at an assisted living? Because that gets loaded, right? Because are they grabbing other residents? These are vulnerable other people who might be my patients too, right? I don't want them being grabbed and groped, right? Sometimes you might have to have this person isolated from other people, right? You don't want to, but and maybe you'll try a medicine with the family just to see, because the alternative is them being isolated from people. How else are we going to, or can the family afford to have a one-on-one person there all the time, right? There's a case of so sexually inappropriate behaviors are very tough, and there are no easy answers. Each case by case. I'll say this though, there are cases like I have several cases where a husband and wife are in the assisted living, and now it's so clear that one agitates the other beyond belief, right? And in their mere presence, and it's almost comical, that the lady with dementia is happy-go-lucky all the time, except when she's around her husband. Then she's yelling at him and agitated, angry. Why didn't you do this? Why didn't you do that? I mean, she is through the roof, and he is really deteriorating because of this, literally, right? And no medicine, she's so happy otherwise. And it's only in front of her husband it's like this. And so what the answer was to take him away as the trigger. Thank God the family could afford her being in one assisted living and him at another, okay? And I got this going on at another one right now. I'm like, listen, he needs to go to the memory unit because they're just at each other's throat. And if they meet each other in the dining room, they're going to follow each other back to the room and and you're going to have to separate them again. This is great. You know, working this out with the family, thank God they can afford 2 separate assisted living apartments, right? And then there was I had another patient who the wife had dementia. Her husband had more physical ailments. Now he's in a wheelchair. The wife was not letting caregivers come into the home to provide care because he's fine, right? And he's fine, not letting caregivers move into an assisted living. She is barricading the door, not letting any caregivers come in, pushing him out of the wheelchair. What are you doing? You don't need a wheelchair, right? And the family are just like, but mom and dad, they've been together for 60 years. They want to spend their life together. It's like, what can we do? And, you know, I convinced them, I said, look, you know, and this isn't the first time they heard this, right? And I said, he is a trigger for her. Nothing's going to stop her from seeing him in bed or in a wheelchair and not try to pull him out of it, okay? And we moved her to a memory care, and it was shocking how calm and fine it went. Another thing, you can never predict how people will do once they move out of their house. You can never predict. I've had so many cases where we're expecting the worst, nothing happens. You expect nothing and the worst happens. I don't know. It just goes on like that.
So Mary,
the more I learn about dementia, the less I can predict, it seems.
This relates to the comment earlier about facilities and you know, differences. So she just mentioned that she worked in 2 geropsych hospitals, and one was great. The other looked only at the bottom line and full beds. A 45-year-old was gero because the patient was known at all other hospitals. She mentioned that that's just a frustrated comment, and I guess I mentioned it in case you didn't see it and might be able to relate to it.
Well, we can all relate to it. And I tell you, I did like 6 months work on inpatient geropsych, and I'm like, I think my calling is keeping people out of geropsych, right? And so, yeah, just try, you know, it's basically like all geropsych is there is for safety, okay? And a lot of times they're there for so long because of placement afterwards, right? Because, you know, it's just such a flawed system. And during COVID, we only had 1 geropsych unit for like all of King County. Then we had none, right? And the CDMH, the county mental health professionals are trying to figure out, you know, how you know, I work hard to keep people from going in the hospital, and there are no hospital beds, right? There's maybe 20 or 25 beds for all of King County. Like, yeah, there's 3 million people here, okay? You know, scarce resources, right? And also, so a lot of people are being hospitalized involuntarily to beds in the emergency room, right? Oh, one thing I want to tell that I didn't include, right? So here's a question that I want to answer before you get there. A lot of family members are always against their loved one going to memory unit. They're recommending memory unit, but they don't want them to go there, okay? And here's my 2 cents to them. And so often I'm having this conversation. Look, we're not putting her there to punish her. And of course, she never wanted to be in a memory unit, right? I get that. But the thing is, she's so confused that when she wakes up in the morning, she just really doesn't know what to do, okay? When she opens up her door at the assisted living, there's a long hallway and she doesn't know, and it's empty, and you know, but there's nobody there, right? A memory unit is closer access to higher staffing, okay? So in other words, that person just needs more queuing, all right? More of the activators of staff. They need more arrows. They need more positive activators. They need easy access. So the person that walks out of the room is just confused. They need somebody right there that says, oh, hey, Alice, you're at the right place. Hey, come on down for dinner, right? They know that they have higher care needs. They know they need to get them dressed and find them and have directed activities, right? So, and so many people, families just wait on the memory unit, and you know, the person's just suffering. I mean, really, they're just sitting in the room with nothing else to do because they can't initiate anything, all right? And because, you know, mom never wanted to go to, nobody wanted to go to memory unit, but mom is not the same person she used to be. And I gotta say, there's something about the quality of life in a memory unit is so if you see them, they're enjoying themselves more than they probably did when they didn't have dementia. That's the fact, just looking at it. Anyway, a person with dementia is how they're doing is written right on their sleeve. It's right there. They're in the moment, and if they're having a good time, they're smiling, they're at ease, then they're doing well. They're not thinking about the past or the future, okay? So we know if they're doing well and what their quality of life is. It's right there in front of us. And if it's going well, cherish it.
Thanks, Huda. Judy mentions that dailycaring.com has wonderful articles on how to address behavioral issues with persons with dementia and can help caregivers too. And there are quite a few comments from people who have said that the information you've presented, the tools, are going to be very helpful for CNAs in their institution.
I was already going to say something else. I don't know why I think like that. What was that? You said Daily Care was a website? Dailycaring.com. I'm checking it out. Yeah, see, this is the story. We need more resources. Like, this is like word of mouth to find information on daily caregiving, right? And families want to know this, right? Gosh, I really hope you guys find these resources helpful, and they're helpful because there's nothing else, it seems, that works that talks about behavior management, right? And it's just so normalized. And families appreciate knowing this is a severe situation, okay? Your mom is not typical, or it is typical, or this is not unusual, and this is where it's heading. They want that expertise, and they need to know where the rubber hits the road, what to expect.
So here's a question about when the person with dementia is in denial of it. Do you pretend that they do not have dementia, or do you continue to tell them that they have dementia? What should caregivers do?
Oh, well, that is you can obviously think of situations where it matters and it doesn't matter, right? I mean, absolutely. So I see people in assisted living, okay? If they are already in assisted living, okay, you don't need to say they have dementia. Guess what? They may agree they have memory problems. Do you agree? It's like, your memory's not as good as it used to be. Oh yeah, that's all we need to, if anything, we need to say, because they're already someplace where people are helping them. But if they won't acknowledge that currently that they shouldn't be driving, right? Or living alone when they can't even get groceries and there's no food in their house, right? But they think it's fine. It's not about recognizing they have dementia. It's about recognizing things aren't safe right now and you can use some help, okay? So find a way. Listen, I got families that say, Dad has to understand it, and basically has to understand he's never going home. And I said, why in the world does he need to know that or say that? Plus, he's going to forget it anyway, right? So listen, they don't need to say it, okay? They don't need to be saying, they don't believe they have dementia. Well, is there anything we can agree on that, they could use some help getting dressed in the morning? That's all that matters, okay? They don't need to agree to it. And they never need to be told that, Mom, you never need to say, this is your home now, you're never going home again, okay? Why not just tell them, I'm a great liar, but it's not a lie. Guess what? The assisted living is only paid month to month. Dad, it's only paid to the end of the month. We'll look for other places, and you're not lying, okay? And you don't need to tell them that the house is sold either, okay? So there's all these things that they don't need to hear because they're not capable of coping with it, is all I'm saying. And do they really need that, right? So when you say, do they need to acknowledge their dementia? Not really.
Mary also said she worked at a general psych hospital with nurses and CNAs who took the time with patients. They used 25 milligrams of trazodone and a walk and chat as the patient calmed down. Any comments about that?
Well, that's great. And that was inpatient, right?
Looks like it.
Yeah. Well, yeah. Listen, what works inpatient, that's great, and it works, but the rubber hit, what's going to happen when that person's outside the hospital, right? And, what I'm saying is, everything that is the hospital isn't when they're outside, right? Will they be in an apartment? Will they be in an assisted living? Will they be in their own home with their family and a paid caregiver or not, right? And who's going to be there when they're agitated, okay? And, you know, it's not about trazodone and spending time with them for 30 minutes and then what? I mean, I don't know what the formula is, but there's a unique formula for every, not just person, but situation, right? Because being in an inpatient hospital is like being at Disneyland. It's a fantasy land that has no bearing on the rest. I mean, like how they do in Geropsych, which is a hospital, is not the same as returning back to your home. Okay, so you have to, people can do just fine in Geropsych and then come back and just be super agitated, and vice versa. I don't know what to tell you. So I often, I'm glad that worked in that situation, but I hope it can work in the other situation too, but you can't count on it.
Are the cards in different languages that you know of?
No, that's a good question. The ABC card, right?
Yeah.
I don't know. Basically, this is me basically bootlegging it almost, So I don't know if UW Washington's, the dementia programs. You know what they do? Absolutely, they do. Actually, but I don't know how to get hold of them. You know what? If you look at, Sue McCurry and the research group with the Seattle Protocol are definitely doing these in multiple languages through Washington and Oregon. I don't know, other than emailing Sue McCurry's office, I think they can hopefully connect you with any resources like that.
And she'll be coming to talk to us. I don't have it readily at hand at the moment when, but just a minute here, I'll see. She will be coming to talk with us the last session, maximizing quality of life across the cognitive continuum on May 31st.
Good time.
So you could ask her then.
Yes, there it is.
All right. Well, let me see. We might have one more.
Oh, wait. Can I tell you one real quick thing? This is hilarious. Oh, I printed up the story, right? Okay, listen. I set up a whole system of reaching out, of my own practice. This is looking outside the box. Set a practice where I get email consents from families, so I can email the families and CC the staff at the assisted living. Brilliant, right? I mean, what we wish, all right? So after talking to the family, I email the family and CC the assisted living staff about, okay, this is the plan. We're going to try this, and, here's some, I give them listen, respect, comfort, redirect, all this stuff, right? I get an email from this husband, and the patient, his wife, is in a memory unit. Huda, I just talked to her and she's the most distraught I've heard in some time now. She says she can't sleep and is just very anxious and wants out of there, and like before, threatens to kill herself. I know that it's just part of the dementia, but she's really struggling, it sounds like. And I see this, I'm like, oh my God, what am I gonna do here? 5 minutes later, this pops up. The assisted living care team writes and goes, hey, after the phone call, she brought me my phone. She said, quote, I told my husband I'm going to kill myself to see if that gets him here to get me, end quote. I think she is very intentional on what she is saying to try to get what she wants versus actually feeling suicidal. She is back walking the hall with her two girlfriends. They are talking about flying places, but they are calm. I love it. These are my people.
Well, Huda, thank you so much. You can tell from all of the comments that this information has just really been invaluable for everyone. Great resource.
I'm really glad to hear that. And, you have my email there. Send me feedback. If you have any better ideas, I'm open to it, right? So I'm really, and give me feedback if you found it useful too. Okay, what's helpful, what's not. I appreciate it. Thank you for having me.
All right, thanks so much. And I'll see all of you next week.
All right.
Bye-bye.